Next, I'd like to introduce our second panel of the day. This is on harmonizing standards towards responsible health AI. And I'd like to welcome back Kurt to the stage to moderate this session.
Yeah, so today we're really excited to have an interdisciplinary group of panelists to talk about standards for responsible AI. And I guess I'll start with this. Nobody wants to do irresponsible AI. And so, in a sense, we're all doing responsible AI, but maybe we're doing it in a different way in different labs or in different clinical care settings. And so this is all about what might be some standards or some best practices that we can talk about for how to do our AI responsibly from the bench to the bedside. And we've really seen today, I think, throughout the meeting, the sessions have started with some pretty fundamental insights about large language models. And as we've gone through the day now, our most recent session was all about really right where the rubber meets the road, where we're implementing these algorithms in clinical care. So really great set of experts that we have today to discuss this with you. The plan for our session is I'm just going to have each of the panelists introduce themselves and say a little bit about the organizations that they work for. And then I'll start with some questions. But as far as I'm concerned, if I don't ask any questions and you ask all the questions, that's fine. So at any point in the session, if you have a question, just come up to the mic. We'll call on you. And I've got Slido right here on my lap. So, and I know Ala has been great in following Slido and asking those questions at the mic, so we'll do that as well. So with that, let's just go down the row, and please introduce yourself and tell us a little about your organization.
Hi, everybody. Suchi, Saria. I went to school here, so always excited to be back. I'm a professor at Johns Hopkins in AI, medicine, and health policy. I also am the co-founder of a clinical AI platform company called Bayesian Health, which we spun out of Stanford. And I also collaborate and partner with several here on the Coalition of Health AI, which is a group championing and spearheading responsible AI.
Good afternoon. Michael Pencina. I'm a chief data scientist for Duke Health and professor of biostatistics and bioinformatics at Duke University. I also work with the Coalition for Health AI, which I co-founded, and my role is kind of between the research side and the health delivery side at Duke, and particularly focused on trustworthy AI and governance and making it serve the patients.
Hi, everyone. Jen Goldsack. I'm the founder and CEO of a 501c3 nonprofit called the Digital Medicine Society. We are a global organization dedicated to advancing the ethical, effective, equitable, and safe use of digital technologies to redefine healthcare and improve lives. I also serve on the board of the Coalition for Health AI.
All right. Nigam Shah. I did not go to Stanford. I just teach here. I think I'll just leave it there.
Good afternoon, everyone. I'm Anika. I'm the Vice President of Innovation and Investments at the SCAN Foundation. The SCAN Foundation is the philanthropic arm of the SCAN Health Plan here in California. Our focus is really on the future of aging, specifically in home and community. And one of our priority areas is around data equity. And you might be asking yourself, okay, why is an aging philanthropy in the AI space? But recognizing that the majority of healthcare cost is attributed to older adults, we need to make sure that AI is working for older adults. 55% of healthcare spending went to the 55 plus demographic. And so as we think about this new wave of transformation that AI is bringing, the question that the SCAN Foundation is posing is how do we democratize it and make sure that it's working for older adults, but really all marginalized populations.
Great, thank you all very much. Next, I guess what I'd like to do, a number of you have mentioned this Coalition for Health AI, and I think it would be helpful for the audience, because not everyone knows about that, to hear a little more about it and its mission. Maybe I'll just start with you, Nigam, if you can just tell the audience more about CHAI. I know you have a meeting on campus later this week, but I know that's a key element that we'll be discussing today.
Absolutely. So there's 4 CHAI board members here. And that might be an accident. I don't think we planned that one. So the idea started with a few of us talking about, every health system had an effort on how to do AI responsibly. As Kurt was saying, nobody wants to do it irresponsibly. And Mike Pencina, John Halamka, Brian Anderson, Suchi, Eric Horwitz, a few of us just started talking like, how are we going to do this? And a web page went up, not an organization, literally a web page. And we wrote something up in Stat News. I see Casey there. Suchi, John, and I wrote something up in March 2022 saying, wouldn't it be nice if we all got together to create guardrails for doing AI right? And the reason this matters is that this is the third AI wave, at least in healthcare, and we'd really like to avoid the third AI winter in healthcare if we can. And then more people started coming. And long story short, in January 2024, we created a new 501c6 organization co-founded by 4 academic medical centers, Hopkins, Duke, Stanford, and Mayo Clinic, or Mayo Clinic platform. And we invited the world in, and I think now about 1,500 to 2,000 people have signed up, 192 or 200 organizations, and a whole slew of other health systems, 16 to be specific, joined as founding members. 4 companies joined as founding members, and we're having our kickoff convening tomorrow at the same place.
Thank you, Nigam. I want to then just pivot a little bit and talk about responsible AI. I think there are so many ways in which AI can be responsible and I suppose could be irresponsible, but I want each of you to give me a sense of how you define responsible AI. Suchi.
Do I have an hour? Yeah. Like how long do I have? So I think really simply, the way I like to think about it is, borrowing from the framework of how regulatory science has approached responsible AI rather than reinventing or inventing the wheel separately for AI. What we mean by this is historically in medicine, when we've thought about responsible anything, we think about it as, is it safe? Is it effective? Is it beneficial? Do the benefits outweigh the risks? And so in that scenario, at a very high level, the napkin sketch of it is, what is it that you're trying to do? So what is the intended use? Who is the user? How are you going to measure whether you're succeeding in doing what you need to do? How are you going to measure all the risks? Do you have a risk mitigation plan? Do you have a way to monitor? What is it that you think you're going to do? And then, as you make any changes, do you have a way to understand that anything you're making changes to is safe and the change is actually effective? So I think to me that framework is just as pertinent to AI as it is to any other type of technology. And the question is, can we take that and then translate it into the practical aspects of what makes, real world AI and AI deployed at the bedside or AI deployed in practical use cases? How do you actually translate those high-level words into measurable things? And that means tooling for measuring all of the things we just spoke about.
Good. So one model is, let's just take the frameworks that we have to be safe and effective and to measure other kinds of technologies, as you say, and to apply that to AI. One of the ways, so Michael, maybe pass it to you next, one of the ways that the current wave of AI is different is that it's so dependent on data and training data. So what are your thoughts on what responsible AI means?
So I think the dependence on data is one element of the difference. The other important element is the methodology itself, right? And I will say, for me, it has been and is a challenge. So I like to say, in the summer of 2022, I felt very good about AI and responsible AI, right? So I'm a Framingham Heart Study investigator, spent 10 years there developing what I call baby AI, right? Regression-based algorithms that people like Suchi laugh at. And then
it is machine learning, however.
But yeah, people say it is machine learning. Some journals, as a reviewer, I had to fight authors who wanted to call a logistic regression and machine learning algorithm, and they were arguing very strongly that it is, and they prevailed. But that aside, I spent my career developing performance metrics, right, for standard regression models. And summer 2022, I said, I've got it, right? You can throw any model at me, whether it's convolutional neural network for imaging. If the task is prediction, we have metrics, we know what they are doing. And then GPT comes along and all my safe world of performance metrics is out the window, right? Because you cannot apply the area under the curve to a generated text. I guess you can in terms of pieces, right? So it's the data, but it's also what the algorithms are doing. So what I did, I kind of went back to principles of what it means. So if you ask me the responsible AI and what it means with data, for me it's number one, it has to serve the human person, right? So it's humans, patients are first in this journey. It's not about the technology companies or who has more data that dictates what is happening, as was discussed during the previous panel. Second is, if it serves the human person, we get to decide what AI is applied to. That's also really important, right? It's again, a lot of innovation, but we have to put it in the context. Number three, we need to be predicting and pre-specifying what adverse consequences might be happening, right? We're trying to build it into our governance framework at Duke. And number four, we need governance, right? What I'm most worried about is that we're going to lose track of what's going on, right? The AI will be pervasive in different pockets, and there will be problems and errors that will be growing like mushrooms, and nobody will know about it. And then they're going to hit, and we will have the third winter in place.
I want to add one clarification, Kurt. I think there's the what and the how. I think the what conceptually of what exists is actually quite good and very strong as a rubric, and maybe there are some tweaks needed. 99%, I think it covers it. I have to date not heard an idea that isn't covered under the rubric. To me, it's the how. So like, for instance, you're saying the differences around drifts and shifts, and these are more around how do we apply the rubric? Like, how do we make sure it is reliable? How do we make sure it's safe and beneficial? Mm-hmm. And I want to make sure because the how will keep changing as the technology changes. But sometimes we're conflating the what and the how, I think.
Mm-hmm. Yeah, so in particular, monitoring after deployment is more important in the current environment, right? And how we do that is going to be a more intense focus, for sure.
Exactly.
Yeah.
And it's like answering the same questions, but making sure like we're now actually answering them. Previously, maybe we didn't think about it as hard because we thought about very offline post-marketing surveillance type things.
Good. Anika, maybe I'll skip down to you. So I know you have this strong interest in aging populations.
Yep.
And part of responsibility has to do with fairness and that our solutions work for all the different groups. And what are your perspectives on that?
Yeah, it's a really important question for us to be thinking about how we are supporting not only all populations and increasingly marginalized populations, but how that's at different sites of care. And so I absolutely agree with what my co-panelists are saying around sort of the standards and oversight and governance that is needed. And I want to ground it in an example that the SCAN Foundation is doing in partnership with the New York City Department of Public Health. Under the leadership of their chief medical officer, Dr. Michelle Morse, with the public health emergency around racism that within the clinic, they started the CIRCA program. CIRCA stands for the Coalition to End Racism in Clinical Algorithms. And again, I get it's clinical algorithms versus AI. But that being said, what's really powerful about the work of the New York City Department of Health and what we've been teaming up to do is that this program started in 2021. And in 3 short years, 11 health systems have signed up, including Mount Sinai, NYP, Northwell, to remove commonly used clinical algorithms that have a race adjustment in them. And the ability to not only identify and do sort of the clinical guidelines and the scientific components of this, but then the change management piece. And they have developed, I think, a fantastic secret sauce around how to bring that change about very rapidly and deploy that within, again, 11 systems. And so that's an example that I feel is really important to share with this audience, because a lot of our conversation today has been around well-resourced academic medical centers, but there is a real need to bring this to public health and to lower cost sites of care and really think about democratization of responsible AI.
Great, thank you for that. I see we have someone at the microphone. Please go ahead. Did you want to make a comment?
Yeah,
okay,
I
go
would.
ahead, and then we'll ask the
There's
question.
something that's really important, actually, that I think sort of I was going to say builds on. I actually think it underpins a lot of the comments that my colleagues have had today, which is, at least for now, AI is an inanimate object, right? It is not in and of itself sort of inherently responsible. So one of the things that I think is actually really important is who are the humans that are responsible and who are we responsible to? And I think, we've used the word patient up here during the discussion, and we've used we. Well, who is we and which patients and which people? And if we want to move from a sick care system to a healthcare system, then it should be for all people. Right? We are responsible to every single person that our healthcare industry exists to serve, whether they are patients today or whether we are trying to prevent them from becoming patients or at least reduce their burden of disease. That's who sort of we are responsible to in all of this. And then who's responsible for this? And unless we're actually willing to say who is responsible, who is accountable, it's very easy to point at the tech as the problem. And the reality is we've done terrible things with data for a long time, right? Redlining, for example, was nothing other than an instantiation of an intent. And how are we thinking about that in an era of AI where the the impact could be far faster and far more broad-reaching? So who is responsible for this? One of the things that I've been working on with colleagues at the National Academies is actually there's a paper coming out, and I think everyone was horrified when I suggested this because it was very practical, there's a RACI that's in there, right? Who's responsible, who's accountable, right? Who's collaborating on this and who's informed, or who's consulted and who's informed. And what's terrifying when you look at that is it's almost exclusively the clinician who's backstopping all of this right now. And that is not going to be a model that works if our goal here is to introduce all of these tools and technologies and ask the clinician to be the last person backstopping this is responsible. That's not going to work. So I want us to be, as a community, more clear about who the we is, who within the we is responsible, who's stepping up, who's saying, I'm going to say that this is responsible. And until we do that, I think we're admiring the problem, we're not solving the problem.
And it gets to the governance questions that Michael raised as well, I think. Yes, please ask your question.
Hello, my name is Samia. I work in the AI on medical imaging field. So all day we've been hearing about the model on one side and then the end users on the other side. Now, I believe University of Michigan published a paper fairly recently, I think this past December or January, talking about the impact of AI on the clinician's ability to diagnose. And they found that when they were presented AI images with AI explanations, their performance to diagnose increased, but when they were presented with biased AI, that it significantly decreased. So the model on one side, the user, the end user, which being probably the clinicians on the other side, there's this whole pipeline of people who will eventually, like for example, medical students, who will eventually become the end user. So how do you envision spearheading, or who do you envision spearheading the infrastructure that's needed to train the people in the middle to kind of mitigate this over-reliance on AI, which we are going to come across often?
Yeah, great. So a couple of different issues embedded in that question. One has to do with what we might broadly call automation bias, or the issues of how humans and machines interact. And yeah, some great research on the fact that a biased AI algorithm will bias the humans, and in fact you take the algorithm away and the humans have learned how to be biased from the algorithm, and that's not a situation that we would like to have, right? So how do we design that system? And so maybe let's start with that, and I'll just open it up to anyone on the panel who wants to. Yeah, Nigam, go ahead.
So it's a fabulous question. If we look at the history of medicine, whenever something complex like this comes in, historically we fork off a new subspecialty to take care of that. When imaging got complex enough, we have radiologists. We have pathologists. Right, I mean, we do need radiologists, right? I mean, there was this, there were claims that they're going to be out of a job. I don't think that's going to happen. We did not have geriatrics as a special discipline. We did not have hospitalist medicine as a special discipline. And as things get complex, we start forking those disciplines. We've already forked a discipline called clinical informatics. But we use these highly trained individuals and use them to babysit Epic. I mean, we have people who are capable of answering all of these kinds of issues in a systematic manner so that we as a profession, as a health system, can absorb and assimilate this technology in a routine flow of business or a routine flow of work. But what's happening is that every medical specialty, there's about 180 of them in this country actually, has their own AI guidance, which is like, why? Why do the pediatricians need to issue separate guidance for how thou shalt do responsible AI from the primary care doctors, from the cardiologists, from the gastroenterologists? And so I think what's needed right now is, to get back to how do we get through this, is we need to get away from a little bit of posturing and chasing the tweet to asking the question, how are we going to do this right in our health system as part of our routine operations? That's the lens with which we need to approach this, the how, as opposed to the what, and producing more PDFs about how thou shalt.
The other aspect of the question had to do with a gap, I think, that we can all agree, and that has to do with just education, right? So we have a workforce out there. I go back to my days. I'm old enough to where MRI just came out when I was a young radiologist in training, and we had to learn a lot about how MRI machines worked so that they didn't, the artifacts that they created because of the physics didn't lead us astray and think that there was a liver lesion where there really was just a phase artifact. And I think the same lesson really needs to be learned all the way from medical school all the way up to the most senior attending physicians, because they're going to need to learn a little bit more about how these new systems work. Anyway, I'm becoming a panelist. I should ask the questions. But does anyone else have comments on kind of education as a gap when it comes to AI and responsible AI?
I can offer some brief thoughts, and then I want to hear from my colleagues at academic medical centers about sort of theirs. I'm really glad you asked the question, because one of the things that I'm starting to hear, and I'm hearing it so often, I'm starting to recoil a bit, is this notion of human in the loop. We're so close to it becoming patient-centered, right? The thing that we all talk about, and then we just move along without ever thinking about that again, and it becomes cheap, and it becomes a way to backstop subpar efforts. For me right now, like, human in the loop feels like it's on the brink of being, I was about to use a very Britishism, a cop-out, right? That we are going to use it as a way to say, like, I'm not sure how well our model performs in this scenario, but there's a human in the loop. Right? What an enormous burden to place upon the clinician. What enormously unfair burden to place upon the clinician, especially if they're not trained. And if we are so worried about standardizing the technology, we need to, and making sure that reaches the necessary levels. How are we thinking about holding that same level to the clinician, not as a stick to beat them with, oh no, because this has to make their lives better. We have an obligation to that, but how are we actually positioning them for success? Especially, we're not seeing a plethora of these things coming down the pike with full liability assumed, right? That liability is still assumed by the clinician who's using them. So I think it's an absolute imperative, and I think our thinking on this has to move as quickly and as aggressively as our thinking around how we actually evaluate the technology itself.
I will add, right, the principles I listed, I reject the human in the loop notion as insufficient, right? It's the image that comes to mind is this electrical connection in series, right? That some nodes are humans, some are algorithms, and they're operating, right? It's kind of, you can say it's trivial to say it has to serve the human person and so on, but it's really not. If it serves the human person is on top. We dictate what the algorithm does. Now, that's not for the purpose of burden. And the other aspect I want to touch on is the clinician fatigue and the trust in the tools, right? We're talking about DAX and all these ambient voice recognition tools, right? That are recording, and it works all well until it doesn't. And I will use a real example from our health system where there is an AI tool, FDA approved, I believe, that does reads of certain imaging. And we had an instance, which we learned anecdotally from the patient, that she received a report suggesting that she has beginnings of a major neurodegenerative disease, right? Signed off by a physician, but it was AI generated. I don't know if he didn't use it, if he fully trusted. She got extremely nervous and worried, set up an appointment, met with the specialist who said, oh no, we see it a lot, you shouldn't worry, it's not indicative of what it told you, right? That's an example. Likely the original doctor that signed off of it just went along with it, what he saw rather than reading. I think there is a huge danger of that that's building up.
The inattentive human in the loop.
Well,
Right.
So-
I want to make a little counterpoint to that, though. So we have had systems in place for decades now that recommend, that warn us about drug-drug interactions or drug allergy alerts in the electronic record. And there's good literature to show that maybe half of those don't get followed by physicians. And so it's very fortunate that we have clinicians in the loop there, right? And they are in charge. And as long as they are gathering all the information, including the AI, which maybe that's old school AI, rule-based AI, but they're gathering all the information and they're making the final decision. Isn't that a good model?
Absolutely. So I don't think it's not a counterpoint. I think I fully agree with what you're saying.
Yeah.
I reject human in the loop, not that the human is not needed. Human needs to be on top, right? Human makes a decision and AI is one of the components. I absolutely agree.
So two things.
And then
We're talking about education, right?
Yeah.
My elder uncle, my dad, and I went to med school 25 years apart. And my uncle's physiology textbook was this much, my dad's was this much, and I had this big. And it's probably like 3 volumes now, right? If we are to really educate our workforce, and I don't mean just doctors, nurses, pharmacists, our entire medical workforce, we have to make space. We have to drop a few things. You can't keep shoving more information into the same 4 years. So that's like one. The other, on the human in the loop, are there any pathologists in the room? We got one hand in the back. How would you like your cell sorter if you had to verify its cell count every time as a human in the loop, right? You would not use it. And so human in the loop, and I'm on record saying this, is a crutch to get out of jail free card right now. Because we have no idea how these things work, what they do to the overall workforce and the care. So we just say, oh, human in the loop, and so I'm out of here. Like nonsense. And so that can only be fixed if we get education right. So where we know what kind of human in the loop we want, check the AI, trust the AI, or let it ride autonomous and take work away from me. All three are human in the loop.
Yeah.
So,
And go ahead, Suchi.
So just, I'll speak a little bit more from the research side. So I think part of the problem today is that we don't have, we want the human to be a part of it, but we don't really have conceptual vocabulary for what is the relationship between the AI and the system, the AI system. And 4 or 5 years ago, we started research in this direction called human-machine teaming. So essentially, when you build a team, you try to figure out what different people's roles are and what are they going to do and how do they interact and collaborate and what is the interface by which they communicate and collaborate, right? And great teams have a way of completing each other's sentences and getting done what needs to get done. So to me, what's missing today is that very often people are releasing a tool saying it's human in the loop, but what they're lacking is a teaming model. If you have a great teaming model, you actually can sort of mitigate some of these risks associated with automation bias and over-reliance. In a good teaming model, you're basically leveraging the strengths of the machine and the strengths of the human. But the human comes and goes and verifies some very specific tasks that they're being asked to verify, which are very quick to verify and easy to verify. And basically, you want to take any particular complicated task and break it up into micro tasks and think about, what is the engagement model and how does that model now protect against the same, the risks, right? Over-reliance, under-reliance, and, you have to write that. So ideally, that would be what a sophisticated, polished tool looks like, a deep understanding of the teaming model. And we've actually implemented this in, use cases and seen like real success in actually, better adoption, better use, better behavior change, and less bias from practice than when we don't have a teaming model and we're in a nonsensical way asking, leaving the human loose or leaving the AI loose to do whatever you want to do.
Great. And I just want to extend Nigam's point just for a minute, and then we're going to go to the microphone. Your analogy to this, let's say, a blood count, okay? Today we have machines that do that, but we have pathologists who are responsible for those machines, and we have quality control on those machines, and if those machines produce a result that's out of whack, then it goes to a human. So there are all of those kinds of processes that we don't necessarily have today for some of our AI algorithms. I think that's what you're arguing for, right?
That's responsible AI.
Right.
I think the
Okay.
pathologists got it.
Yeah. Yes.
Ali Abayazin, I'm a neuroradiologist and a graduate student in the Masters of Clinical Informatics and Healthcare Management here. First of all, thank you all for everything you do for the field, and especially my mentors, Kurt and Nigam. I wanted to go back to the idea of governance and the importance of that. I want to add also kind of having rigorous governance and just not pure governance, and get some feedback from you on the workforce deficiency when it comes to data scientists in the healthcare system as a whole. I mean, here at Stanford, we're fortunate that we have a lot of data scientists, but I'm part of a team that are looking into this, and healthcare only hires 2% of data scientists out there compared to other industry. It's estimated that 66% of healthcare systems don't have enough data scientists to even deal with their epic issues. So how are they even going to deal with AI implementation and doing governance? And I wonder if having more rigorous data science into this healthcare system can bear some of the responsibility, because they have to do the utility assessment, the workload assessment, the stuff that Nigam teaches us about all the time, workload assessment, the monitoring and the update. Will that take some of the responsibility away from the huge responsibility from clinicians like myself, having to actually follow up on every mistake that an AI does when I'm reading scans and have to report that to the vendors and so on. And the vendors, they don't have a lot of accessibility to every healthcare system to do that, which is another layer of problem. So thank you.
Who on the panel wants to try that?
I think what you're describing, I think there is a lot of depth to it. I think it speaks to organizational maturity, right? And a lot of questions hiding what you're saying, right? So the data science workforce, is it for development of these algorithms or for maintenance, implementation, and monitoring, right? The question of development is interesting. Is it going to be health systems? Is it going to be external vendors, right? Smaller companies, larger companies? Right now, it's extremely easy to turn off an epic algorithm, right, which a lot of systems default to, right? A lot of CMIOs and leaders say, don't want to bother with everything. I'll just turn on what's given to me, which that's dangerous in its own right. And I think you're absolutely right that we need a cadre, not only of data scientists, but clinical experts, nurses, right, patient voices in the governance system to make sure that these tools are doing what they need to. And there is a huge workforce development need to make it happen. But I think that's the maturity of a health system prepared for AI, having this system that you're referencing and Nigam is teaching about.
That's AI creating jobs.
It is, but that's a problem if you're running at a negative margin and everyone is fleeing the town that you live in and you are the last hospital or health system there. Yep. So I think one of the things, and it's been, a theme of our panel, but we've been good. We've answered the questions, whether it's about sort of workforce. I think we, because things are moving so quickly, unsurprisingly are quite heads down, trying to address the challenge that we're facing today, instead of popping our heads up and sort of steering for the curve ahead. Nigam, in the same way that you said, if we need to train clinicians on this, what are we going to take away? My question is, for a healthcare system that's running at a negative margin or a 1% margin or a 2% margin, and you need to hire data scientists, given the supply and demand issue, they also don't have a cybersecurity expert, which frankly is even more terrifying to me right now, right? These are the sorts of things. What are we going to do in terms of allowing them to have more throughput, or to allow to unlock the capacity so that a clinician who doesn't work all day and then do the pajama time and then, could you serve on this governance committee? No, I'd rather not, actually. I'd rather sleep just now and again, right? These are the sorts of problems that we have to sort of think about. What does it mean to be a clinician in 5 years in an AI-enabled healthcare system, right? Are we training sort of experts for the status quo today, or are we training for a future state? What is an interdisciplinary workforce in 5 years, in 10 years? How are we thinking about revenue models? How are we thinking about cost savings that actually support the investment that we need to make in humans? And I think unless we pop our heads up and think a little bit more about what is the future state we're actually driving for here? What is our North Star as a community as we do all of this? We're going to make very short-term decisions that will become ossified and will go on to hurt us.
100%. Jen, I just want to build upon that, because when we think about lower cost sites of care, your FQHCs, your safety net hospitals, again, zero to low margin, and not having necessarily the talent available. And when we think about rural health, they are not going to have the talent available. So a point that Nigam made yesterday was around, what does scale look like? So we're in a season of exploration and ideation, and a lot of that is happening in, in wealthier, talent-rich, well-networked communities. But to Jen's point of, if we don't think about where we're going, we are not going to be able to provide these solutions to those who need it the most. And so how do we create capacity now to think about that, and who's responsible for that? Because it's an upfront investment when it is far more attractive to go to well-funded, well-resourced communities first.
So we're going to have to go to a lightning round because we have about 5 minutes left and there's a line at the mic. So please ask your question, and I'll try to restrict it to maybe one respondent here on the panel. Go ahead.
So hi, my name is Praveen, and I'm a student researcher in high school. In the topic of responsible health AI, bias is such a prevalent concern. And I know we touched on automation bias, but there's also other forms of bias such as gender, racial, and also neurodiverse bias as well. So my question is, what are the most effective methods of detecting and mitigating these types of bias in health AI systems? But more importantly, how can we distribute these effective methods across different healthcare applications?
Thank you for being here. I see a bright future for you.
Thank you.
Do you want to try? Who wants to take that?
I mean, I'll speak to one component of it, and I won't get to, I'll leave it to the others to talk technical. But, at the SCAN Foundation, we talk about age bias and how that's showing up already in the algorithms we are seeing in the clinic. And so there's different points of part of the development journey where we need to be mitigating bias. So it's starting with the developers and understanding the data sets that they are using, and understanding also the bias that they as individuals are bringing to the development process. It's then, where are they deploying it, and what is the site of care, and what is that environment? And again, to the maturity point that Michael was making around health systems. And again, some have more structure and governance and ways of working and oversight. Some will not. So how do we recognize that and acknowledge that as a part of bias mitigation? But we all know that these models drift in the wild. And so how do we have the appropriate monitoring, and who is accountable? What I have observed is that there's a game of this already happening. And so how do we, to Jen's point again on sort of putting a RACI together, as a brass tacks as that is, there's a level of transparency around accountability and monitoring that is a must. So I see it across the development life cycle.
And that's something I think that, we talked about Chai earlier. That's something that I think Chai is trying to address too, is to provide a playbook or models for lower resource institutions to try to do this right.
Yeah, I would just give one quote from our chief medical officer on bias, and he says, when you talk about bias in a health system, don't look out the window, look in the mirror.
Yeah, okay. Next question.
My name is Nagesh Malagari, and I work on the technology and strategy side. Talking about responsibility in today's topic earlier also, it touched on trust. How do we make sure these AI technologies or solutions we're building are trustworthy? And in the past, when we built most predictive systems, we had clear verification and validation, right? It's designing per design versus, or it's working per design versus, and working as the user intended, right? How do you kind of like bring that kind of at least transparency to some of these generative AI stuff, And also, is there a way to kind of bring in explainability along with some kind of trustworthy score?
Great. So yeah, who wants to talk about trustworthiness, transparency, and explainability? Nigam.
Yeah, I have a penchant for punishment, right? I want you to imagine a Venn diagram with 3 circles, and one of them is the engineering explanation, one circle of the top one, let's say, the engineering explanation of why or how does the model produce the number or the output or the generation it is produced. So a mechanistic explanation. One of the other circles is the causal explanation. And the third one is whatever you provide to engender trust. So this Venn diagram gives you 7 zones. And whenever these words, transparency, explainability, trust, come up, you need to be crystal clear which of these 7 zones you're in. Because if the desire is to convince the end user to trust your output and follow along, providing the engineering explanation often backfires. If the desire is to explain why, so somebody can ideate a mitigating intervention, and you give a black box, it backfires. And so we're mixing words here, explainability, trust, and transparency, and so on. So the thing I would leave you with is ask for what purpose is an explanation being sought, and sort it into this Venn diagram. It'll point you in the right direction.
Yeah. And I think that's a great point. Trustworthiness is what we're after. And just remember, there are many things in medicine that we don't know how they work, but we trust them because we've had clinical trials that show if you use this, the patients do better. And so that's another form of another way we can establish trustworthiness of AI, even though it may remain a black box. Ron, I'm sorry, we're out of time. Thank you. We'll have to take your question offline. But I just want to thank the panelists. Magnificent discussion today. Great conversation. Thank you all for your questions. Now we have a break, and we'll reconvene at 3 o'clock.